want to give a really great introduction just for everyone to understand about Dr. David Lewerenz. I have some notes on here. He's an assistant professor of ophthalmology at the University of Colorado School of Medicine. He graduated from the UAB School of Optometry, and he previously had a private practice in Salina, Kansas. And what's most important and why we love to host and work with him time and time again is that he's a clinical diplomat in low vision and has served as chair of the Academy of the American Academy Optometry Low Vision section and the Vision Rehabilitation section of the AOA. So Dr. David Lewerenz, thank you so much for joining us today.
Thank you very much for having me.
My pleasure. Listen, we'll go ahead and, it's been so great, these past several months. There's been a lot of different changes and whatnot. And I think we'll go ahead and explore a little bit about what you've done and what you've seen there.
Hello, everybody. Thanks for being here. It's a pleasure to chat with you. So I'm calling this, as you may be able to see, the low vision rehabilitation in the age of social distancing. And I have to begin with a disclaimer. I'm not an expert in the field of virtual health or telehealth or coronavirus or epidemiology or anything like that. I guess if Anthony Fauci can claim yesterday that he is not the end all of experts, I can certainly say the same thing. So what I'm really looking forward to is I'm going to try to keep my comments fairly brief so that there'll be plenty of time for all of you to offer your thoughts and ideas. I'm really interested to hearing those. So thanks again to eSIGHT for inviting me. Thanks to all of you for attending, and I have no disclosures to make relevant to this presentation. So in my simple way of looking at this, as I see it, we're going to kind of go through three different phases. One phase is the virtual health phase only, when it's just not safe to be face-to-face with patients. I think in a lot of places, that phase is still in effect, but in many more places, I think that is kind of coming to a close, and we're cautiously going into the second phase of limited and very cautious face-to-face visits. So that'll be the kind of the second thing I'll talk about. And then after that, at the point where the coronavirus is kind of a very bad but distant memory, and we get back to normal scheduling and kind of regular practices, I think things are going to be different. I think we're going to be affected by what we've been through, and so we'll talk about that a little bit. The advantages of virtual health in low vision rehab are the obvious one, is that it's a much safer, a totally safe environment. Although it's a very contagious virus, it cannot be communicated via Wi-Fi. So it's a very safe environment to conduct patient care and client care in. And that's a very good thing, because many of our patients and more than a few of our providers are in the age range or that they are at risk for severe complications from COVID. And of course, we also know that complications can occur at any age. I did a volunteer shift in the COVID ICU at our hospital, an overnight shift, which was something I hadn't done in a long time. It surprised me. There were 24 people on this particular ward in ICU. Probably 20 of those 24 were on ventilators, and only about 6 were 70 or older. It was a very eye-opening experience for me to help out on that floor and see what was going on there. But another advantage of virtual health, in addition to its obvious safety factor, is it does keep us in touch with our patients or clients, whatever you happen to call them in the environment in which you work. And we can continue to work on those people's goals. So it does keep us in touch with them. It maintains that connection with people. It might not be the same as a face-to-face visit, but it's a lot better than nothing. And we can stay in touch with people and let them know that we're here to help them and that there's a lot we can do to assist them with whatever their goals are. And there are some visual metrics that we can take in a telehealth visit. I'm not going to do it right now, but at the end of my slides, I will show you a method that I've developed for measuring visual acuity during a virtual health visit, which is, I think, approaches, if measurements can be taken accurately, I think it almost approaches clinical accuracy in terms of measuring visual acuity. Of course, the challenges of virtual health visits in low vision rehab are you can't do everything. In my particular case, you can't do a refraction. You can't evaluate a patient's performances very well with different devices and strategies that you might have in mind to help them with their goals. Our communication with the patient is a bit more limited. Like all of us, I'm sure, we begin to communicate with the patient before we even get to the exam room. We're watching them as we walk them back there, and we're seeing how they operate from a mobility perspective. We learn a little bit during their interactions with their family members. We begin to learn about what's the social dynamic in the family unit. What's the dependency situation like from the patient to the family member that accompanied them. And it certainly, it's less of an emotional connection when you're doing a virtual health visit rather than a face-to-face. More than a few tears are shed in low vision evaluations and in follow-ups. It's a very emotional thing for people to have vision loss, especially if it's fairly recent onset. And it's there are a lot of tears shed, and there are people are very often so incredibly grateful for what the things that we are able to offer them that it's not unusual to get a hug from a patient or a family member at the end. So it's that's another thing that I think we'll miss a little bit in virtual health compared with a standard face-to-face visit. In my particular case, I feel very fortunate to have a lot of coworkers to collaborate with. We're always bouncing ideas off each other to try to help people with their problems. I have two occupational therapists, Amy Dobbs and Leah Munches, and then the optometrist who started our program here at the University of Colorado is Dr. Cara Hansen, and I work with her every day. So it's during virtual health, you're kind of on your own. And so that's another challenge, is that it's more difficult to work in a collaborative sort of way. But maybe we just haven't been imaginative enough. I wouldn't want to get on Zoom for every single patient I see, but there might be other ways that we can be creative in becoming more collaborative during virtual health kinds of environments. The types of there are different types of virtual health visits. One is just a simple phone call. And in that case, obviously you're lacking the video element, but for most of a virtual health visit, probably the vast majority of the time, the provider is sitting there looking at the patient or client's face, and the patient is looking at the provider's face. And after a while, you're going to get about as much information as you're going to get. There's still a lot of obvious advantages to video, but you can get a lot done just with the audio component alone. And just recently, I've had many experiences over the last couple of months with patients who were struggling with the use of a device or some kind of strategy that we had recommended that they try. And we were able to work quite a few of those problems out over just a simple phone call without going all the way to a total audio-visual platform. The other option is, of course, to add the video component. And you can do that rather informally with just regular consumer platforms such as FaceTime, Duo, and Zoom. Ordinarily, these kinds of platforms would not qualify, is my understanding, under HIPAA regulations, but during these virtual distancing times, those regulations are being, I don't know if they've been waived or if they're just promise not to enforce them. But there are places, my wife had a virtual health visit just a couple days ago with her physician on FaceTime. So I know doctors are doing that. Now you can go, and our department is doing this, to a more formal and a more secure platform. It's usually linked through the electronic medical records system of your institution, or through a patient portal that the practice or clinic might have access to. This is more secure, but it's also more complicated for the patient. When our system was initially rolled out to us and said, this is how we're going to be doing virtual health visits, we actually decided that we just weren't going to do it in low vision. It seemed like it was just too much for our patients to handle, given the the age of most of our patients. Just looking at what we know, if you take a group of people under 30, only about 2 people out of 1,000 are going to be visually impaired. But if you take a group of people over 80, that's about 230 people out of 1,000. So it's almost a quarter. So obviously the age distribution in low vision is across the entire spectrum, but it's heavily weighted in the older population. And you can't just assume that an older person is not tech savvy, but there is a little bit of a relationship there. There are some very tech savvy people out there. The very first patient of ours who got an eSIGHT, for example, was in his 80s. But he was a retired software engineer. He was very menu driven, and he caught right on to the menu driven operation of an eSIGHT and did very well with it. So you shouldn't prejudge people based on their age in terms of their tech savviness, but we just thought it was too complicated. But it was streamlined, and there are some things you can do to make it go a little bit more smoothly. One thing is to have an introductory call ahead of the telehealth visit, the virtual health visit, by the provider, or we're fortunate here, we have staff members doing this. Every patient is contacted. They are making sure that the patient knows how to access either the portal or the whatever it is that the platform is going to operate inside of. And they could do kind of a dry run with the patient to make sure everything's working, so that when I get a call with the patient, initiate the virtual health visit maybe the next day, it goes very smoothly. It's just, and again, it's kind of deceiving because it seems easy to me, but I know that there was a lot of work done in the background to make it go smoothly. I think it's good for the patient or the client to understand that there are some limits as to what we can accomplish in this environment, and we will have some idea of what to expect out of the visit. In face-to-face visits, I've always been extremely opposed to the idea of writing things down on paper and then staying at the clinic until 7 o'clock at night, entering all that into the computer again. Except in virtual health, since I'm doing most of them on my laptop where I only have one monitor from home, that's basically what I've been doing because it's just too difficult to have on a very small 13-inch laptop splitting the screen between the EHR and the virtual health visit software. If you're really doing a lot of this, I would think it would be essential to have a dual monitor setup so that you can have the electronic medical record on one monitor, have the virtual health platform on the second monitor, and just seamlessly go back and forth between the two. If you want to really record things as you go into the computer, that would be just a huge advantage. The types of visits best suited to virtual health. I have not done any. Now, there's a difference between my partner here, Dr. Hansen, and I. I have not done any initial evaluations on a brand new patient via telehealth. I just felt there just wasn't too much I could accomplish. On the other hand, my Dr. Hansen has, and I'll have to qualify that. She's not doing the initial evaluation. She's doing kind of a pre-evaluation. She's done virtual health visits with several of her patients that are scheduled for next week, And she has gotten a lot of their history down. She's gotten, you know, what are their primary goals that they're working on? What are their struggles? What are the dynamics in their life that's making their vision problem may be a real challenge for them? What are their goals? And so when that patient does arrive, she feels as though she'll be able to hit the ground running and be able to maybe even see more patients in a day if she has done that ahead of time. So that's something that you can consider. And anytime a patient's having a problem or facing a new challenge, I would encourage you to encourage your patients to just reach out to you if they're having a problem. And certain kind of goal-oriented limited visits can be accomplished very effectively via virtual health. I'll give you a brief example. I have a patient who had a very late onset, very unusual late onset of Leber's hereditary optic neuropathy. He didn't develop symptoms till he was in his late 50s, early 60s. Very, very unusual for that condition. When he first came to see me a couple of years ago, it was all about driving for him. Driving was, you know, he had other goals, but like if you were to rank his goals, 10 goals, the top 8 would be driving. You know, that was his main goal. So we did a complete program with him. He was fit with a bioptic telescope. He went through a complete behind the wheel driver's rehabilitation program with certified professionals in that. And he managed to keep his license, has a safe driving record. And then after we went through all that, our department became one of the clinical sites for gene therapy for LHON. He went through the gene therapy, and like many of the people in that study, had a significant, not profound, but a significant noticeable improvement in vision. And to the point that his bioptic was maybe a little bit on the strong side, but still he was doing well with it. But one of the research coordinators called me one day during the quarantine and said, Tony is having some new challenges. He's trying to do things around the house. I put this picture up of a guy using a screwdriver to remind me to tell this story. And he's having trouble just doing home repairs. He can't see the head of a screw very well when he's in a kind of a dark corner of the house trying to work on something. And so I gave him a call. We talked about a lot of different options. I gave him about a half a dozen different ideas that he could consider. And I really think that we resolved his issue just about as well over the phone as we could have, or on a virtual health visit, as we could have face-to-face. So it's not ideal, but there are certain types of visits that I think focused, goal-oriented visits that can work pretty well with virtual. We, and I'm sure many of you, are in the kind of the limited but very cautious return to face-to-face care. Here are some of the precautions we're taking here at our institution. And first, from kind of the patient's side of things. The patients are all getting a pre-visit telephone screening where they're asked, have you been exposed to this virus? What have been your symptoms? The patient I'm seeing this afternoon, the first patient that I've seen face-to-face in 2 months, his son had COVID. So yes, he had exposure, but he's right at the 2-week period. He's been tested positive, he's been tested negative, the patient has, and he's asymptomatic. So the fact that he was exposed, but it's been 2 weeks, he's asymptomatic and tested negative, so we'll go ahead and see him this afternoon. And they're also asked about where they've traveled to recently. We have limited building access. Not all the doors to our building are open. We've greatly restricted that. The initial check-in is done when the patient drives into the parking lot. They're told to call a phone number, and the initial check-in is done. And they know when they come that they have to wear a mask. Any family member that comes with them must wear a mask. We have none of our waiting rooms. They're roped off, not being used. The patient is escorted. They're met at the front door and they're escorted straight to the exam room. No stopping anywhere in between. Only one family member can come in with the patient. Probably in more than any other specialty area, low vision almost always has a family member with them. But no family members under 16 can accompany the patient, and only one can do so. When the appointment's over, they're escorted right back out to that main door. They go to the parking lot and they do their checkout and make their next appointment over the phone. So again, not much happening at the front desk and absolutely nothing happening in the waiting rooms. From the provider perspective, we have very limited schedules. It hasn't affected us in low vision that much, but if you were a retinal specialist or a glaucoma specialist and you're accustomed to seeing 50, 60 visits a day, that's been greatly curtailed. They're seeing about maybe 25 to 30% of their pre-COVID volume. We fit under, in low vision, we take a lot of time with each patient, and so we fall under that limit, and it hasn't really affected our scheduling too much. All the schedules have been staggered. Dr. Hansen and I never have an 8 o'clock patient at the same time. Mine might be at 8 o'clock, hers might be at 8:15. So patients aren't meeting each other in the hallway. Providers all wear masks. In low vision, we've been told that we need to wear an N95 mask. If you happen to know me and you've seen me before and you wondered what happened to his beard, well, that's because you can't wear an N95 mask and have a beard. So remember that, York, if you ever need to be fit with the 95 mask, you're going to lose that beard. We're wearing gloves and we're wiping down the rooms between each appointment. Beginning next week, our PDI wipes might be repurposed to the ICUs in places where they're needed more urgently, in which case we'll be using bleach wipes, which you have to wait 10 minutes for bleach to work. And some types of equipment shouldn't really be wiped down with bleach. So we're facing some issues with that. Will the world be different after the coronavirus is defeated? I really think that virtual health will probably continue. We're going to find that virtual health visits are more valuable than we think. And this isn't just in eye care, and it's not just in low vision. I'm sure you saw the news yesterday that the CEO of Twitter said, you know, we're just not coming back to the office. People are going to work from home forever. And we're going to save all that money that we spend in expensive downtown San Francisco real estate. That's going to be really tough on the people who sell lunches and do dry cleaning in downtown centers. One corporation after another is finding that that working from home works better than they thought, and they're just going to go to that. I think we're going to find that virtual health might work better than we think. And, you know, working at a medical center, we see people who travel from neighboring states. They travel a long way to see us. Unfortunately, too often these types of visits are lost to follow-up because it's just difficult to get people to travel 8 hours to come back for a follow-up. I think we're going to do more follow-up using virtual health. So I think we're going to discover some things. Awareness of hygiene is also going to change, not only affecting medical visits, but also social norms such as hugging, handshaking. We might rethink a lot of those things going forward. I'll have to thank my colleague down at University of Texas at Houston, Bhavani Iyer, who approached me about difficulties she was having. She was doing a lot of virtual health visits. She probably ought to be giving this talk instead of me, but she was having difficulty getting a good visual acuity. And so I thought, well, I'm going to work on that. And so in just a minute, I'm going to show you what I've come up with. You could have a chart that you could email to the patient and have them print it and put it on the wall and stand 10 feet away. That the American Academy of Ophthalmology has such a chart, but not everybody has a printer. A lot of my patients don't even use a real computer. They use their phone, they use their tablet. I'm sure you're seeing a lot of the same things, but personal computers are not as frequently used as they once were. If you're going to use an on-screen type of visual acuity chart, it's really difficult to get one that's going to adapt to the size of the screen. The size of the letters or the optotypes are going to be much smaller if you're using your phone than they are on a full-size desktop computer. So I'm just going to say thank you for your attention, and thanks again to eSIGHT for inviting me to talk. I'm going to just show you quickly the visual acuity chart and system that I have, and then we'll open it up for more discussion. You can email the file, it's a PDF file, you can email it to the patient. But an easier way, if your virtual health platform supports it, is to simply share your screen with them. So you have the patient measure this arrow, okay? We'll get back to that measurement in just a minute. Now, the patient may not have a measuring device handy. They might not have a ruler or a tape measure handy. So the instructions have some examples there. For example, a credit card measures 2.1 inches by 3.4 inches. Currency in the United States is 2.6 inches by 6.1 inches. A standard piece of paper is 8.5 by 11 inches. If you live in an enlightened country like Canada, you might have to convert those to centimeters, but you can use common household everyday items to kind of estimate the length of the arrow. The second thing you do is you estimate the distance from the eyes to the screen. Again, if there's not a measuring device handy, you can have the patient reach out and just barely touch their screen with their their arm extended as far as possible. And for a person of short stature, maybe 5 feet tall or so, that's going to be on average about 22 inches. If you're extremely tall, maybe 6'6" or so, that'd be about 34 inches. So you can estimate that. And if you'll use the page down button on the chart, we're going to start with some large optotypes, go down. This goes in 0.1 logmar steps, so it's a logmar visual acuity chart. These last two slides either approximate or are equivalent to ETDRS standards. And I've added some red and green lines there to help communication between the provider and the patient to see what line they're on. So that brings us to the last part of it. Say that they read that OKZNR line right below the red line. Okay, that's where the spreadsheet comes in. So let's say that they were working on their tablet. Can you see the spreadsheet now? Okay, say that they estimated that the arrow was about the length of a dollar bill, so that's 6.1 inches. And say that they didn't have anything to measure with, but they were, say, 5 feet 5 inches tall. So we're going to estimate their arm to the tip of their finger is probably maybe 23.5 inches. So let's put 23.5 in. And then you'll see that these, all the letters will now populate. So they read the OKZNR row, the row right below the red line, which the red line is also on the spreadsheet. That's 20/74. So that's how this chart works. So it's the visual acuity system I have is 3 files. You can write to Jordan or York. They have them. They can share them with you. You can write to me. I'll be happy to share them with you. They've been posted on some list serves, and I've heard that the American Optometric Association is going to put them on the Vision Rehab website. So let's look at the chat questions here.
For sure. There's a few chat questions. I'll highlight one to begin with. You were saying to an individual the other day about how to prescribe low vision aids via telehealth. Do you want to go ahead and answer that one?
I don't know that I've prescribed any low vision aids via telehealth. I think that's really possible. You can't really do the kinds of evaluations, and how are you going to get those devices to the patient? What I did, the story that I did tell with my patient with LHON was he had a very specific problem. And I'll just go through the options. He said, you know, when I'm in the corner of a dark, working on something in the house, I can't see to connect my screwdriver with the screw head. And we went through a variety of options. The first one I said, you know, go to Lowe's or Home Depot and get a head-mounted flashlight. One that you don't have to hold, you can control the light. Said if that's not enough, if adding illumination isn't enough, we have head-mounted, what I call a visor magnifier in different powers. And we just never use them anymore without the built-in light that we can get for them. So that way you get a little magnification and a brighter light. I said there's also head-mounted devices, such as eSIGHT is one example that can be used as a, you need something hands-free if you're going to do a task such as that. And so we talked about different devices, but we couldn't really evaluate them. I think he was on the borderline of being able to do it by himself the way it was. It wasn't that he needed a huge amount of help given his level of vision at this point. So, you know, we also talked about the use of his bioptic, which does focus down to a short distance. So that was more discussing strategies. It wasn't that we were prescribing something. We did kind of come up with a list of things, that a prioritized list that he was going to go down and try. But the way we evaluate low vision devices anyway, I really don't know how that could be done through virtual health by itself. Interested to hear if people have other thoughts on that.
For sure. I'm trying to go in order here of when things came in, just to keep everyone apprised. So just a comment, the Doximity app, this was in relation to video calling. The Doximity app has a video call capability that is HIPAA compliant and very easy to use. It does not require computer or email access, just a smartphone. It is much easier to use than our VA video telehealth system. So figured I'd share that with the group as that chat came in. And there are quite a few questions, several here, just about being able to share this presentation offline with our other clinics. Just want to hear from you on that.
I'm happy to make my slides available. Now, I'm not sure if you're talking about just my slides or if you would, I know this is being recorded. If I'm okay with sharing anything that we're doing. If you want my slides, I'll be happy to send my slides to anyone who wants them. I'm sure that Jordan and York have this entire thing recorded and will probably be posted probably on Facebook, it looks like. So I'm sure they would share that link. And of course, as I've said, the files that I've come up with for the visual acuity chart are already being shared, and very happy to share those. The visual acuity chart, by the way, in talking about the Doximity app, works well on phones, as even if that arrow, if you take the example we just had, say that arrow was only 2 inches long, I'm going back to the spreadsheet, you still have a range of visual acuities from 20/3 to 20/600. So it's a pretty wide range of visual acuities on that chart.
Fantastic. That's super helpful, and I'm sure we'll gather the information to be able to share accordingly. So thank you so much for that. The next question that I see here is, which EHR do you use for low vision?
Our entire clinic, our entire medical center is on Epic. So we're on Epic, which is based, it's one of the big 2 or 3 EHRs for the country. Its headquarters are in Wisconsin, and Epic is what we're using.
Fantastic. The next question we have, is the acuity measurement considered distance or near visual acuity?
Well, that's an interesting question. If the patient is wearing the correct lenses, and if say that they're wearing progressives and they just tilt their head to get things at the right distance, visual acuity is an angular measurement. It's really, it's closer than distance visual acuity, but it's further away than most near visual acuities in low vision. So it's somewhere in between. Theoretically, if the lighting conditions are the same, if the contrast of the chart and the illumination of the chart is the same, if the crowding of the letters on the chart is the same, and the patient is looking through an appropriate correction, there shouldn't be any difference between distance and near visual acuity. So you could call it what you want. And if you really want to get more of a distance visual acuity, you could have the patient back up to 10 feet and put 120 inches in there for the test distance. So it could be a true distance visual acuity if you wanted it.
Fantastic. I have a question here from John Boyer. How are you handling DMV renewals with or without the Goldman visual fields?
Well, hello, John. Up in Oregon, I presume. Good to see that you're here. I have not done any DMV renewals through virtual health at this point. And there's no way that I know of to do a Goldman equivalent kind of visual field through a virtual health visit. So, you know, in our state and many others, I think the DMV was shut down for quite a while. Everything was just put on hold. I think that, and I do have a patient coming in next week whose license is going to expire at the end of May. We had to kind of work him in after hours. So we are making exceptions to getting people in to maintain their licensure if their vision supports it. But I don't really know how virtual health could be a very valuable tool in that, especially as he pointed out, because we can't get visual fields that way. Not that I know of. If someone has a better idea on that, I'd be very happy to hear it.
I have another question here. Are you billing for these visits currently?
Yes, there have been a few phone calls that I haven't. They were very informal and spur of the moment things, but even phone calls are billable. But yes, we have guidelines issued through our medical center for how to bill for virtual visits. It's a whole, under our billing page, it's just a whole new section. And it's pretty much based on time because the exam elements are pretty limited. So it's a time-based telehealth visit. I can't cite the codes right off the top of my head, but and it might vary a little bit with what certain institutions have decided to do. But yes, we are billing for virtual health visits.
And I'm curious for myself and other listeners who may be visually impaired themselves. I know you mentioned reach out at any given time, reach out to your provider, whether it's early onset or you've been visually impaired for a long time. Are there any key factors, say for myself, if I was starting to experience visual issues, that I would begin that first phone call or start to reach out? Is there anything else you would say to that?
Mm-hmm. Well, if you're noticing changes in your vision, that certainly is a good opportunity for a phone call to your provider. And we have an entire telephone triage system in our department that is, where either one of our ophthalmology residents or one of the optometrists on faculty kind of takes call for that. And if the call center gets a call of someone who's had a change in their vision, then we talk to one of these screeners, and then we get them to the appropriate specialist. There's kind of two concerns when a person experiences a change in their vision. One is, have they had a change in their eyes? So the first order of business needs to be, if they have macular degeneration and they notice a big change in their vision, they should see their retinal specialist before they see the vision rehab person. If they have keratoconus, they should see their anterior segment specialist before they see the low vision specialist. So we work very collaborative here in our department. I love working here, and they appreciate what we do. And for that reason, I would defer to the specialist who's caring for their underlying health condition first, to make sure that they don't have something that can be treated medically. And then if not, then they would be referred back to me to work with them in low vision rehab.
That's very helpful. I got several comments here. I'm just going to read them out so everyone can hear. Most likely in response to being able to have a device sent out to patients. I just ordered a monocular for a patient after a video visit. He was unable to see text on the TV from his chair. I had him walk forward until he could see the text and estimate the distance. Used the chair distance and that measurement to order a 2.5 times monocular, and we'll do another video visit for training.
I love it. That's fantastic. That's Deborah McConaughey. I see that. Yeah,
yes,
that's fantastic. You're absolutely right. If you did send out, say, a 2.5x telescope and they couldn't see it from their chair, but they could see it from half that distance, then you could do the math on that and determine, well, maybe they need a 5x. I mean, it's pretty simple math, and you can use using what we call relative distance magnification by changing the distance and then using that to alter the power. Excellent idea. I love it.
There's a few other comments here. One other one says, we have been mailing a continuous text near chart prior to speaking with the client. It has been helpful to recommend an illuminated magnifier, but direct observation is only available if we speak via Zoom or FaceTime or other video conferencing.
Yeah, that's a definite. You could have we use continuous text charts for prescribing near devices very routinely in our clinic. There's no real substitute for that. Single letter visual acuity just isn't the same as continuous text, and it's not as valuable if you're prescribing for reading. So that's a really great idea for taking kind of the gold standard clinical practice and using it in the context of a virtual health visit, of sending out a printed continuous text chart and then observing the patient as they're using it. That could work. I think that's being very creative, and I really like that idea.
Beautiful, and something that we've tested in the past as well, just with eSIGHT. So I definitely know that sending that out can be helpful for many different patients and clients. I have two other comments here, both from the same individual. One says, use EM codes, bill by time, and use CPT or CMS designated time list and identify which you used. And then the other comment from that same individual was that your hair looks good, but keep supporting your local businesses.
Appreciate it. Both good comments. That's what we're doing coding wise, and I appreciate I don't want to put the barbers out of business. I really don't. So thank you. Appreciate it.
We have just two other questions, actually from Facebook, from individuals watching there. Is there a way to check your eye pressures via virtual help, like the virtual field test?
Mm-hmm. I used to be involved in treatment of glaucoma. I'm not so much anymore, and I might be a little bit behind the times. I know that they are coming out with with measuring devices that can be used from home. In the same way that we've had blood pressure devices where people can check their blood pressure at home, we've had those for years. They are coming out with ways that check the intraocular pressure that can be used at home. And they're even coming out with smart contact lenses. I don't know if this is really going to be effective. I think they're still in the prototype stage, that measures intraocular pressure continuously. So I think we're going to have ways of doing it. I really can't comment. Perhaps someone else on the call can, as to what devices are out there now that can be used to check intraocular pressure at home. I would think that they would exist. I'm just not sure what they are.
That's best answer sometimes is I don't know, and sometimes that's okay too. I think one last question, again, just from Facebook, from some of our viewers there. Worrying about getting a new prescription right now, is there any issues that you've heard of in terms of dilating pupils and a higher risk to COVID-19?
I'm not sure I understand the question. I'm sure that maybe I misunderstood, but having a dilated pupil, I'm sure, does not increase your risk. I can't understand how that could increase your risk for getting the virus. In terms of getting your glasses prescription, there are plenty of people who dilate, who do refractions and prescribe glasses for people who are dilated. I'm not one of them. I prefer not to refract people who are dilated, but other people have different approaches to that. So I hope I answered that question. If I didn't, please elaborate, and I'll try again.
I think that was I think that's what we were looking for, anyways.
Okay.
I think the answer was there. We got just a couple of minutes left here, and I would be remiss if I didn't do a few things just at the end of this. One thing we discussed before this call, Dr. Lewerenz, was the fact of visually impaired people, people living with visual impairments around the world, being in isolation a lot of the time. We work with so many individuals that could potentially feel, they're really out there on their own. And we actually had a couple of eSIGHT users and a couple of other people speaking with us saying that COVID-19 has really given us an understanding of what that social isolation can be, not being able to go out completely freely, not being able to experience what everyone else is going about doing or remembering a time that happened. And I'll say from eSIGHT, you know, we're here to help, whether it's your clinics, whether it's you personally, to be able to get out there and be part of what we're trying to do is helping more people connect, helping more people live lives more independently. You know, whether it's something for your clinic to be able to work in telehealth and remotely. We have some practices. We work with doctors across the board, and we work with quite a few number of individuals to make sure that our practices are really the best and can really help a lot of individuals. I'm going to put our information just on the screen over here. But Dr. Lewerenz, I just want to thank you, and I'm sure everyone else that has joined this webinar. Extremely informative, very helpful, hopefully, to many of the practices out there. And I think it comes to us being able to serve people more effectively, you and your clinics, wherever that may be. Find something to help out with. We'll be sure to share the information from this webinar to everyone who went ahead and registered. We'll get those slides from Dr. Lewerenz, and really nothing better than just saying thank you, Dr. Lewerenz, for everything you were able to provide today.
My pleasure. Thanks to everybody for joining. Thanks for eSIGHT for hosting.
Thank you once again for joining us today, and we hope you have a wonderful rest of your day, and everyone should stay safe, and we'll all get through this together.